Welcome to the Neuroscience Education Institute podcast. I'm Dr. Sabrina Siegel with NEI, and today my guest is Dr. Jonathan Meyer. So the topic that we are discussing today, as many of you know, psychosis is something that can be very difficult to treat in patients with Parkinson's. And there is a new molecule, pimavanserin, that may be very helpful in treating this, and it may have other uses as well. Do you think you could tell us a little bit more about that, Dr. Meyer, and tell us your thoughts on that?
Absolutely. So as many of you may or may not know, psychosis is actually very prevalent in people with Parkinson's disease. It's an estimated about 50% may develop psychosis at some point, and it's not due to the drugs. People used to actually call it levodopa psychosis, thinking it was because of the dopamine agonist therapy. But what we've recognized is that it is an inherent problem of the disease itself. As people start to lose serotonergic neurons, they get upregulation of serotonin 2A postsynaptic receptors in certain cortical sites. And these receptors become super sensitive. And what happens because of this is that we actually get psychosis. And the best analogy is that this increased serotonin signal through serotonin 2A is very similar to what happens when people take LSD. LSD is a potent serotonin 2A agonist. So folks really had trouble treating psychosis and Parkinson's disease because they could simply not give dopamine antagonists to these patients because they would develop motoric worsening. In the early 90s, people started using clozapine to treat this because it was the first atypical antipsychotic. And what was interesting is that not only did it worked at very tiny doses, meaning 6.25 to 25 milligrams. And some smart people kind of figured out over time that at those tiny doses, its most prominent pharmacologic property was serotonin 2A antagonism. So in recent years, as a lot of the atypicals did not work well for Parkinson's disease psychosis, this molecule pimavanserin was synthesized and found to have a unique purpose for Parkinson's disease psychosis. And the way it works is that it is a very potent serotonin 2A inverse agonist. Its Ki is sub-nanomolar. It's 0.087. It is the most potent serotonin 2A inverse agonist that we have, and because it has no affinity for dopamine receptors, you can give it to people with Parkinson's disease psychosis. It will specifically address their underlying pathology of upregulation and supersensitivity of serotonin 2A receptors without worsening their motor symptoms. Now, no drug works for everybody. Clearly, there's people for whom it doesn't work, but when it was approved in 2016, it was a game changer for people with Parkinson's disease psychosis. What's interesting about the molecule is that it also has some affinity for serotonin 2C. So this is a property which many of you might know, which lends itself to antidepressant uses. And so among the interesting studies that are going on with pimavanserin now are two groups. One group of studies is focusing on using pimavanserin adjunctively with antidepressants for people who have difficult to treat unipolar major depression. So the idea is we are adding on a very potent serotonin 2C antagonist to somebody on existing antidepressant therapy to provide an additional antidepressant mechanism. So these studies are ongoing. Certainly the theory behind it is sound, and we think this is something which may actually be very promising on the basis of the neuropharmacology. The other use of pimavanserin, which is being investigated heavily, is whether in fact this antipsychotic property could also be used in another group of people for whom traditional antipsychotics have issues, and that's people with dementia-related psychosis and aggression. As most of you know, all of the antipsychotics have mortality warnings when treating dementia-related psychosis, and of course nothing is indicated right now. So if pimavanserin works out in this population, potentially it might be an agent which doesn't have some of these other safety issues that we've seen with antipsychotics, including not only mortality, but also the stroke warning as well. I can't predict whether it will work or not, but certainly it's a very interesting application of this. The last use of pimavanserin, which is also very interesting, is whether this really potent serotonin 2A inverse agonism does anything when added on to other antipsychotics. Most of you know that atypical antipsychotics were actually designed to be somewhat similar to clozapine. They have serotonin 2A inverse agonism or antagonism built in, but not nearly as potent as pimavanserin. And based on some early work with a risperidone augmentation trial, there is some possibility that the addition of pimavanserin, even to an atypical, might improve the treatment profile, whether it's positive symptoms or negative symptoms. If this works out, I can't speculate. It's very interesting, and we'll have to see where these clinical trials go. But it's just nice to have a new agent which maybe doesn't have a lot of the older safety issues of medications that were being given to people, especially with Parkinson's disease or dementia of the Alzheimer's type. Whether it works for the dementia-related psychosis or aggression, nobody knows, but it's certainly a promising avenue of research and something we hope we'll see some positive data in the near future.
Well, that all sounds very exciting. Thank you so much, Dr. Meyer, and thanks for tuning in to the Neuroscience Education Podcast.